With some types of cancers, incontinence and erectile dysfunction in men is fairly common. Also, just because you're getting older doesn't mean these things shouldn't be working right. Welcome to the Recovery Room podcast, because in this episode we are talking about incontinence and erectile dysfunction in men, because guys have a pelvic floor too. We welcome back to the show a national expert in pelvic floor rehab, Vitek. Just because pelvic floor issues may be common after surgery doesn't mean it's normal, that it should just be accepted, or that it shouldn't be addressed and fixed. This is the Recovery Room podcast, discussing all things cancer and cancer recovery. We bring you the experts, accuracy, understanding, and next steps you need to be healthier, more confident, make better decisions, and live your best life after cancer. Vitek, welcome to the Recovery Room podcast. So glad to have you here.
Thanks, Leslie.
All right. So you are an occupational therapist. And matter of fact, you're nationally known. You have a clinical specialty in pelvic floor therapy. So super pumped to talk to you today. And today we're kind of focusing on guys and their pelvic floor. And so when we talk about pelvic floor, like the three, there's pain and all sorts of stuff. But today we're kind of focusing on incontinence, which can be urinary, it can be fecal, and also erectile dysfunction, because that all kind of has to do with the pelvic floor. And then there's a handful of cancers that affect the pelvic floor, and radiation can affect the pelvic floor. So we're talking about prostate's probably by far the most common, but you'll see rectal cancers, bowel cancers, anal cancers, and anything that's radiated near there can affect all that stuff. So when you look at the data, this is a pretty gosh darn common. I mean, just looking at radical prostatectomy, it's more than 50% of these people coming out of that surgery end up having some either urinary incontinence and or erectile dysfunction. Isn't that correct?
Yes. Very, very common to see that. Definitely right after surgery, within the first few weeks, there's still some issues potentially, like after having the catheter removed and everything after the surgical procedure. And then there's a lot of recovery time. Nobody has some healing time to do. Okay.
So can you first of all, what the heck is the pelvic floor? Can you talk to Joe on the street and just say, what does that mean? What is that?
Yes. Yeah, a lot of guys don't really think about their pelvic floor because
nobody hardly does. It's just like, what is that? Everybody has one, whether you're male or female. You got one. Exactly. What is it?
Yeah. So the pelvis is, the base of our trunk area, and kind of like bowl shaped. And at the base, the pelvic floor is from your pubic bone in the front to your tailbone in the back, basically forming like a sling of muscle between your legs.
Right. And
the muscles surround all of the openings. So they surround the base of the penis, and then they go into and surround the anal area. Mm-hmm. So that bowl of muscle is really holding up the bladder, which then underneath that is the prostate, if the gentleman still has one, and then the pelvic floor below that. So the anatomy is that the pelvic floor is at the base of all of that. That structure. And then it also holds in the colon rectum in the back area.
Yeah. Because people, you don't think about it, but the pelvis is kind of on the side. So you got your trunk like this. The pelvis is kind of like over here. So literally the bottom of your trunk, if the muscles weren't there, everything would just fall out. Exactly. So I think that's a good kind of visual of why it is incredibly important to keep the pelvic floor strong. And when you're talking about pelvic floor strength, you're talking about muscles, literally muscles.
Yep. Just like any other muscle in the body. Yeah. If you don't use it, you lose it, or maybe we need to retrain it potentially if there's been a surgical procedure or you've had a medical event, and we need to work on getting those muscles working correctly for the functions they're needed for. Yeah.
And I think it's so important to, just have these open dialogues, open conversations, because if this were a total knee replacement or rotator cuff surgery, you would go to OT or PT, right? Which it's automatic. You would never give somebody do knee surgery or shoulder surgery without giving them rehab afterwards.
That's right.
But people that are having surgeries that affect the pelvic floor don't always get a rehab referral, which is really frustrating because maybe you won't need a lot of rehab. Maybe you just need 1 or 2 visits, but other people are train wrecks and they might need a lot. And we really don't know how much you need until a pelvic floor therapist, which again can be an occupational therapist or a physical therapist. We don't know until you actually get an exam by them so we can figure out, hey, you look great. Because sometimes you guys are going to recognize issues that the person may not. And there's a lot of preventative stuff that you can do as well, because because for at least people that are going to have prostate cancer surgery, which is called the radical prostatectomy, there is evidence that if somebody comes and sees a pelvic floor therapist before their surgery, that you can actually improve the outcome afterwards. Can you tell us about that?
Yes, that's exactly right, Leslie. So they've looked in the research a lot at preoperative therapies, and to kind of get that education prior to the surgery, like, well, what am I going to have to do to get this muscle kind of toned up or ready to work when I'm out of surgery? And also just kind of getting used to the coordination of how does this muscle even work? Because a lot of guys haven't even ever tried to use this muscle before. And
it's something you don't normally think about until it's not working.
Exactly, right? And the pelvic floor is huge for our quality of life. I mean, it has control of all of our really vital bathroom functions and our sexual function. And so hugely important to understand how it works and how the surgery may impact its function and the function of your bladder and or your bowel and the erectile function so that you can do something about it, because there's really good evidence that shows we can make some improvements with therapy, and we might as well try to really put the recovery on the fast track instead of letting the body just kind of do its thing. And then maybe a year later thinking, well, now I could get a rehab referral. Well, maybe we could have put things on the fast track if we do it a little sooner. So that pre-op, just like you said, Leslie, like before a knee surgery, before hip surgery, that's become really standard. And really, I do see a ton of men pre-prostatectomy as well. Which is super helpful for them.
I always compare it to because people with cancer are really busy. They're really stressed out. They're kind of scared. They have a billion appointments. They have a billion imaging scans. But so do people who have, like strokes and serious other health conditions, and they've got a lot of copays. Everything's really expensive. But we would never walk into a room with a guy in it that just had a stroke and say, you know what, Mr. Smith, you're pretty stressed out right now. You got a lot going on. You have a lot of copays. Let's just skip your rehab. And if you still can't walk in a year, then maybe you can visit us. We would never do that. Ever would we do that. But we're doing that to our guys that have these pelvic floor cancers. And it's really frustrating. So, and I think it's also just normalizing the conversation because I don't know how often, again, whether you're male or female, talking about your urinary incontinence it's not, typical lunchroom conversation. It's not something you're going to maybe bring up at work. Sometimes it's even hard to bring up with your partner. And then you throw in, for guys, erectile dysfunction. It's a mess. And it really deserves conversation. So I'm really glad that you're with us this evening. So we've talked about urinary incontinence, fecal incontinence, and erectile dysfunction. Can you really just quickly just define what each one of those is, just so we kind of have, because people are probably guessing, but tell us what those things are.
Sure. So urinary incontinence has a couple definitions. We think about it as basically leakage of urine involuntarily or when you don't want it to be coming out.
Okay.
So for example, stress incontinence is if you cough or you laugh or you sneeze and a little bit of leakage comes out. Okay. That is most common in men after a prostate removal. Not very common in men pre-prostate surgery because the males have really long urethras. So stress incontinence is not very common.
Interesting.
Removed.
Yeah.
The second kind is urge incontinence. And that would be you kind of get that gotta go feeling, rush to the restroom and it's coming out. That can be really common pre-prostate or even after prostate removal because the prostate is like blocking sometimes the urethra and there's some obstruction there and it makes the bladder unstable and it causes this bladder like irritability or these involuntary bladder contractions that cause those urges to be really strong. And then when the prostate's removed, now the bladder's like free for all and those urges can be really strong. And now there's nothing basically supporting the male's urethra in that area.
Right.
And the surgery, the urethra gets basically surgically attached to the base of the bladder. And so there's a lot of healing that has to go on with that surgery. And men have an internal and external sphincter there. And so those nerves are just disrupted so much during that surgery. There's healing time that has to go on. And so those urges are harder to control and the pelvic floor has to be much stronger to hold those urges back.
Yep.
Then there's something called mixed incontinence, and that would be if someone has both some of that stress incontinence, laugh, cough, sneeze, leakage, as well as the urge incontinence. So those are probably the most common. Sometimes there's something called urinary retention, where you can't relax enough to get the bladder to empty. And so you might get something called overflow incontinence, where the bladder has to push it out. Otherwise, your bladder is just too filled. That's a little bit less common, I would say, but sometimes we have to check for that, use a bladder scan, or there might be some other interventions we would use differently with that. And then fecal incontinence, as you mentioned, would just be a leakage of a little bit of feces involuntarily through the anal area. And that could happen for a variety of reasons. Maybe the stool is looser, harder to hold.
Right. Yep.
So consistency of stool is something we work on in pelvic floor therapy, and diet recommendations, fluid recommendations, things like that. And then the last thing you mentioned was erectile dysfunction. And so the pelvic floor muscles play a role in maintaining blood flow in the penile tissue in order to maintain a rigid erection. And so the nerves that are around the prostate, when you get a prostatectomy, the doctor will try to salvage those nerves in something called nerve sparing when you hear that term. But those nerves are now under some level of shock afterward.
Right.
It's difficult for men to then obtain the same level of erection, at least right away, post-surgery. So there can be up to a 1 to 2 year recovery time for the shock in those nerves. So it can be a process. But having a stronger pelvic floor assists in all of the things we just talked about. So being stronger to support the bladder, support the urges. I work on a lot of, trying to get that muscle to work to support when you cough, sneeze, or laugh, those kind of things. We can help with fecal incontinence, and we can also get that muscle stronger for erectile function as well.
Okay. So typically you got bladder, which is kind of a round little sac. Okay. And then underneath the bladder, so then the urethra, which is the tube that runs from the bladder and then to the outside through the penis and out to the body. That's where the tube, the urine comes out in. So that runs. So you got bladder, the tube coming out the bottom. All right. And then the prostate is right underneath that, and the urethra runs through the middle of it. So when the prostatectomy, which is basically removal of the prostate, that urethra, that tube has to be physically removed from the body. Okay. And then reattached to the bottom of the bladder, which is what you were talking about. So that can kind of mess up the whole incontinence thing. And then many of those erectile function nerves are actually on the back of the prostate. So they have to very gently be taken off, which is the nerve sparing. So that's why, I don't care if you're Superman or if you can bench press 1,000 pounds. If you've had this surgery, it doesn't mean how tough you are. This crap can happen to you, and it's really, really tough. But like you said earlier, we in rehab don't have to rehab what the person doesn't lose. So if we can get people in earlier, you said it perfectly. We fast track people to a quicker and higher recovery level, because if you just let people just sit there, they're going to go backwards. And yeah, we can fix that stuff. We have a heck of a lot further way to go if we just catch this stuff early.
Yeah, and I think the quality of life too, Leslie. It's
it's huge.
Having some control over the process and how fast you're healing, where you can actually do something about it, is huge. Yeah.
Yeah, it's cancer is sometimes so passive. Like surgery is passive, chemo is passive, radiation is passive, but this is something you can actually do to take some control. It may not make it perfect, but it can make it a heck of a lot better. And it's a massive quality of life issue. It's a massive functional issue, and everybody deserves to have the best quality of life and the best medical care all the way through. So this is really important.
We can make these programs very doable.
Yeah.
At home, a lot of these exercises, very private. You can kind of do them anywhere.
Right. Yeah, you can't see. You can do them in the car while you're driving. So we'll talk about that in a second. But so what should guys look for? All right, what's normal and what's not normal, and because I've heard this happens to everybody. So people just live with crap that they shouldn't have to live with. So what's normal, what's not normal, and what do you watch for, and when should you seek medical care or say, hey doc, this is a problem, you got to send me somewhere.
Yeah. So the bladder should be able to hold anywhere from a cup to 2 cups of urine at a time. And then you would obviously have to go to the bathroom, right? So about 5 to 8 times a day is average. Men tend to probably go maybe just generally a little bit on the lower end of that.
Frequency wise, you mean?
Yeah, a little
Okay,
bit
less frequent. Okay.
5 to 8 would still be within the normal range.
Mhm.
You shouldn't really have to get up at night, maybe 0 to 1 times a night. Sometimes with that enlarged prostate, that can be a trigger for getting up a lot more at nighttime.
Mhm.
That's something also that we can help with, even if someone has BPH, so the benign prostate hypertrophy. So we
Mhm.
that enlarged prostate, and maybe they don't have cancer. We can still work on these things to reduce the nighttime frequency, the daytime frequency, if those are an issue, because that's common for BPH. So
Yeah, and sleep disruption is horrible for
yes.
psyche, for for just mental health and physical health.
So
It's
there's
tough.
some great things we can do.
Yeah. So if you're waking up pretty frequently to use the restroom, and it's not because you're drinking a gallon of water before you went to bed, definitely talk to your physician, because that's not okay and it's not normal.
Yep. Okay. So we want to do that for sure. You shouldn't leak at all. There should be no leakage.
Okay. No leaking. Right.
It doesn't matter if you're 70, 80, 90, or 20. You should not be having urine leakage or fecal leakage. So that's important. Now, as far as like your intake, you should take about 64 ounces of water in a day. That's for a good, healthy bladder and bowel. That's, the average person. Sometimes they say half your body weight in ounces. That's kind of the newer recommendation.
Okay.
But for some people, that's a lot of water and it's not, appropriate for them. So we kind of gauge that and we work on that in therapy. But something to kind of shoot for is that 8 glasses or 64 ounces in a day. So that would be, a normal range of intake as well. The bladder can do really well for you if you have that right amount of water and you have the right pelvic floor. We'll talk about in a little bit, and we should tell the doctor when things aren't right, for sure. Absolutely.
Okay. And how about erectile dysfunction? I mean, if the erection's just there but off a little bit, or doesn't last as long, or nothing's happening, none of that is normal, right? Or what is
exactly that would not be normal at all. So the issue with erectile dysfunction is it's usually multifaceted. Probably can be related to many other things other than the pelvic floor. The pelvic floor is one piece of the puzzle.
Yep. Okay.
It may be blood pressure related, if you have diabetes, testosterone levels. So there's a lot of things related to erectile function that can be involved. So the physician is kind of a good first line for erectile dysfunction. Usually the people that I see are coming to me because they have a urinary and bowel issue, and then that's a secondary issue that we're hoping that we can have an effect on with pelvic floor work.
Okay. All right. So if people are like, this just doesn't feel normal, or this is not okay, it shouldn't be okay. I always say and a lot of times it's common after surgery, but just because it's common doesn't mean that it's normal and that it can't be fixed. So just because that's the way it is doesn't necessarily mean that's the way it has to be. So make sure that you're not accepting things that you don't have to accept, and really talk with your physician. And if they're not listening, talk to somebody else, because you deserve care.
Another thing, Leslie, just to keep in mind for guys too, that just came to mind as far as normal versus not normal, is that you shouldn't have to strain or push to urinate.
Yes.
It shouldn't be like an effort.
Right.
And really for bowels too. So constipation is a big thing that I work with as well. So not just the incontinence piece, but the constipation. So I work with people on, trying to work through those issues as well. Okay. Constipation can cause bladder issues. So it's always kind of a combo issue sometimes that we talk about. So keeping that in mind too, as well.
Okay. All right. So we recommend people go to their physician or advanced nurse practitioner or physician assistant to just get diagnosed, make sure that there isn't any of this other stuff going on, and then make sure you get a referral to a pelvic floor therapist. So what is a typical, because they're like, why am I going to an OT or PT for this? I mean, what is a typical value? What can a guy expect when they walk in your door? And are they going to have to, pull their pants down? I mean, it's got to be kind of creepy. So tell us what happens.
Yeah, sure. Absolutely. So kind of the first session, depending on time and how many symptoms someone has, is really like intake and kind of getting to know the person. I want to hear their story. Tell me, what's going on? How long has this been going on? Did you notice a particular time that this all started? Was there an incident or a time that you noticed it happen because of surgery, or is it just like random? It kind of developed over time. So we kind of establish a historical perspective of that and get a history medical wise and what kind of medications you're taking and such like that. Put that all together. And then I really want to know specifically, we're going to go through your bladder, how many times do you go to the bathroom a day? Do you go at night? What does it look like if you have incontinence? Tell me about that. Tell me how much is leaking. If you are having the leakage, do you currently have to wear a pad? Those kind of things. Do you strain to go to the bathroom? Does it hurt?
Yeah.
Maybe I do a little questions like screen for UTI or something, which is the bladder infection. Do you have odor in your urine? Is your urine dark, or is it like more lemonade colored, which would be more normal? So just kind of getting that history down for what's really going on with the bladder. Are you having urgency? All that kind of stuff. And then from there, also asking about bowels. Are you having a regular bowel movement? Ideally, I'd like to hear daily, but sometimes that's not the case. Three times a week is still considered medically normal. But
the range is really normal. Yeah.
Yeah. Most people aren't like super comfortable if it's only 3 times a week, but and we can kind of talk about ways to improve that, of course. Do you have to strain? Do you have to push? Is it painful? Is there any bleeding, hemorrhoids, those kind of things? We talk about the consistency of the bowel movement. So there's something called the Bristol stool chart. So from 1 to 7, we talk about 1 being hard stool all the way to 7 being like loose, watery stool, and trying to get somewhere in the middle, like a 4, which is snake-like and soft, and really just thinking about like, where's that person at baseline? And then I ask about sexual health and, are they in a relationship with someone? Can they have an erection now? Tell me about that. And then we can address that as well. And then I just want to know, what do they drink each day? What do they eat? How do they sleep? What is their exercise habit? So we just get that baseline right off the bat. And then from there, I explain the pelvic floor. I have a model, a physical model with the muscles, with the bladder, with the prostate to show the full anatomy in layman's terms. And we just kind of talk about what that really looks like. I instruct on how to contract the muscle or squeeze the pelvic floor or relax the pelvic floor and just talk about it in general terms. And then we can kind of talk about some of the physical assessment techniques that we can use. So typically, I do like to suggest a potential assessment with biofeedback. So using a little sensor. So for men, this sensor either can be internal, and it's just like the size of a pinky, goes into the anal rectal area. So not into the urethra or the penis or anything. Okay. Goes into the anal rectal area. It's pretty small. A lot of men are, they want to see it. They want to understand it. Yep. And maybe they are not comfortable with it. It really depends. But I have external ones as well, little stickers that can go just on the skin. So it's just a way to get an objective measurement on a computer to see like, what is your muscle doing? When you squeeze it, what happens? When you relax it, what happens? Let's get a real true look at it so I can prescribe you a personalized home exercise program. Right. Okay? Or I can do a physical muscle exam, digital, like with my finger, and we can assess the muscles internally or even just externally. Or if that isn't comfortable, there's a lot of ways we can just talk about learning how to use this muscle. The person can stay clothed if that's more comfortable for them. And we can try to learn it using external palpation. They can palpate themselves. I can teach them how to use a mirror at home on their own if they do not want me to assess it. So there's a lot of options. It does not have to be that they have to disrobe, but that might be how I might be able to help them the best, but it's not required by any means.
So patient is always in control.
Absolutely.
This is the world of informed consent. Nobody can touch you, push you, do anything to you that you do not say, yes, I agree to that. Now there's, pros and cons to each of those things, but again, it's always up to the patient, and they should know that walking in the door. Yeah.
I like to give people the options, the things that I'm capable of doing or providing, pros and cons, and then they can decide. They make the decision.
Yeah. Okay. So again, depending on the severity of the dysfunction or the length of the problem list, you can then say, I want to see you next week, or, hey, I'm going to show you these exercises. Come see me in 6 months. It's all over the board. Correct?
Correct. Yep. Usually post prostatectomy. So right after the prostatectomy, we maybe will see the person about 6 weeks after. So there's some healing that's happened. And then if we assess at about 6 weeks, I usually, if there's a lot of concern, we may do like a once a week appointment.
Okay. Yeah.
Okay? And if there's moderate to not too much concern, we may do every 2 weeks, every 3 weeks, every month, somewhere in that range. More to just kind of keep going on the progress and giving suggestions or educations as the person heals. If there's new ideas needed or strategies that we can suggest. Yeah.
Okay. And then you talked about like dry needling and exercises. And so what are some things that you can use?
Yeah. So some things that we might do like in the clinic would be teaching the exercises, like learning how do we squeeze this muscle, how do we relax this muscle. So doing some work with that and understanding how to do that. We may do some, like you mentioned, dry needling. So dry needling is where you use it's a really, really thin needle, kind of like an acupuncture needle, a little bit longer, and it's placed in the muscle belly near or around the muscles that aren't doing what they're supposed to be doing. And they really, in regards to pelvic health, it's to modulate the nervous system, to really get into those nerves that are trying to heal, to function in the pelvic floor area, to help them function more normally. So we use those to facilitate functional gain of the muscle themselves. We can also facilitate bladder function and bowel function with needles into the nervous system itself as well. So it's a unique treatment that gets right into the nervous system that we can, each person's a little different. I use them differently for each person, but it can be a really successful treatment to get directly into the nervous system for healing.
Dry needling is used by a lot of rehab therapists, like rotator cuff, the knee, the hip. So again, the pelvic floor is muscle. So again, using dry needling, if it's appropriate for the right person, it can be a very, very effective tool in getting those muscles to function better. So if people are like, what do you mean you're going to dry needle the pelvic floor? It's the same concept. They're muscles. It doesn't matter where they are, what direction they're going, they're muscles. So
yeah, exactly. Okay. And the spine controls the pelvic area and the organs there. So I can needle in the spine and we can work on just the communication from spine to pelvic floor. And it's very successful treatment. Yeah. Some other things I do too in the clinic, Leslie, is like manual therapies. So if somebody is having like trigger points or pain in their pelvic floor, or there's tight muscles related to the incontinence or the issues they're experiencing, or even erectile function can be affected by too tight of muscles. Right. You may need to work on certain muscles, or I can teach the kind of carryover of some self-release manual techniques. There's lots of ways men can release their own muscle once they learn how to do it in the clinic. So it's a really, there's great tools out there as well to reach internal muscles. You wouldn't even think of all the things that they've come up with. I mean, it's amazing. It happens to be that there's something called a pelvic wand. And for men, it's, an S-shaped curve, and you can get it into the anorectal area, and I can teach you how to release certain muscles if we find that they're tight. And it can be extremely beneficial and successful for just all around pelvic health issues. Not everyone needs that, but it's something available. And there's external techniques as well. So it doesn't have to be internal techniques.
Because even radiation can shrink stuff a lot too.
Exactly. There's actually some brand new anorectal progressive dilators out there that can help with the fibrosis of the anorectal canal. That are very comfortable. They're silicone, so they're soft and flexible, and very slowly progressing because that can be painful to stretch those tissues. And it's an outstanding product, and that can be something super beneficial, especially with anal cancer, rectal cancer, where people are experiencing like pencil-sized stools where they get very narrow.
That's got to be horrible. Yes.
So we can do something about that. That is something we can really, really work on. And I do a lot of like abdominal work. So men get a lot of symptoms of pelvic pain sometimes in the penile area or in the testicle region. A lot of times it's coming from abdominal areas. So I do a lot of abdominal work for men as well.
Yeah. Okay. Yeah, because, scar tissue development and fibrosis from radiation, that's a physiological process that I can't control, physician can't control, patient can't control. It is what it is. Your body just will create scar tissue and create fibrosis as a result of what's happened to it. And it needs to be dealt with. Some people get very, very little. Some people can get over the top too much. And if those symptoms need to be treated, there's ways to take care of that. So very good. And then obviously there's the good old exercises that people do at home.
Exactly. So squeeze and relax, or self-release, or all these other, I give a home program that's very, very individualized to that person's needs.
And then along with the aerobic exercise and all of that other stuff. And Yeah. And especially for people who have had surgery and then will follow up that surgery with either more chemotherapy or chemotherapy for the first time or more radiation or new radiation. It is really, really important to make sure that you're keeping your legs strong, your arms strong, your core strong, and you're getting in a good aerobic exercise program. So it's all really, 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 really important.
Yeah.
So what are your favorite, give us like three of your top resources. I mean, where can guys go to learn more about this?
Sure. Yeah. So one of my favorite resources for erectile dysfunction is called atouchysubject.com. Yep, it's a great website.
Okay.
She has this free educational modules thing that you can sign up for. And her name's Victoria. She is majors in psychology, and she's from the other side of the world, but she has just this awesome platform. And so you basically get one module emailed to you a day for 6 modules. Okay. And it's just a really nice basis of, tell me about erectile dysfunction, tell me what I can do about it. And they are outstanding and free. So it's really great. She has a website, atouchysubject.com, where she has all of these like videos and available tools for erectile dysfunction, pumps, and different ways that you can work through that. She does a lot of YouTube stuff where she talks to specialists in this area.
Oh, nice.
All kinds of great ideas for how to work through that. So that's one of my favorite ones.
Okay.
There's also something called intimaterose.com, run by a physical therapist. She has a specific men's health section. So you do have to find the men's health section. And she has all of her tools listed that she has for men. She's got this great anal-rectal dilator kit that is, for men that may have had that anal cancer, rectal cancer, colon cancer, where we might need to do some stretching down there. It's an outstanding kit. And then she's got the pelvic wand, which is really, really great as well. So there's some great resources there as well. She also has videos on how to use her equipment as well. Nice. And then the other thing for incontinence for men, there's all these things you can get, like you could get a handheld urinal, you could, just for management, or wear a pad or something. But there's some unique ones out there. One's called the Men's Liberty, and it's an external catheter system for men that has this little butterfly shaped kind of sticky area that you can put just on the end of the penis that attaches to a bag. So it's kind of a temporary external catheter that's not like the full condom, because sometimes men get very irritated with the full condom catheter. Yes. And so I love the Men's Liberty device. If you apply it correctly, it's very good at controlling small amounts of incontinence to protect you. Like say you have to go on an airplane for a while, or want to wear it at night so you don't have to worry about leaking into the bed or something like that. So that's a nice option if you can't tolerate the condom cath, the traditional condom cath. And then there's also these other, for really active men, if you just have like a little bit of leakage, like after a prostatectomy, there's these cuffs that you can wear on the end of the penis. So it's just like this small pad. It's very discreet. So you could be wearing your regular, clothes, your regular underwear. But it's just a little cuff that you can get. You can search on Amazon and penile cuff, and it's really nice. It's a real gentle little strap that you can place on the end, and it's very discreet. So those are probably my favorite men's products that I recommend. But again, it's individualized, but those are some nice ones. So
okay. Oh, awesome. So are there any like myths that you need to bust for guys?
Yeah.
What are your thoughts on that?
Just because you're getting old doesn't mean these things shouldn't be working right.
Right.
We should address them. There's things we can do. I think aging is the biggest myth that people think because I'm older. And a lot of physicians and nurses will say that. Yeah. And that's not okay. So is it true to say that incontinence is never normal? Yes. It's never normal.
Incontinence is never normal. Okay. So that's awesome. That's an awesome myth.
Yep. That's the biggest myth right there.
All right. Love it. All right. Well, Erica Vitek, pelvic floor specialist, thank you so much. Men in general don't sometimes get the level of care. It's interesting. Healthcare, sometimes women don't get the level of care that men do, but in this area, men definitely do not get the attention and care that women do. So it's really important that we talk about this stuff, normalize this stuff, spread the information, and make sure that people know that this is not okay, and you deserve treatment because you deserve to be fine and live your best life ever. So thank you so much for being with us today. Thank you, everyone, for joining us on the Recovery Room podcast. Please feel free to share your experiences in the comment section below. Would love to know your thoughts and whether you've tried pelvic floor therapy or how much difficulty did you have after your surgery and or radiation, and was it addressed by your medical team? I'd love to know, so please share your thoughts. Erica, thanks again.
Thanks.
We'll talk soon. Bye, everyone. In this episode on incontinence and erectile dysfunction in men, we talked about the myths, common problems, and the barriers to care men often face when needing help with issues related to their pelvic floor. We reviewed the steps to follow if you need help and what to expect on your first visit to a pelvic floor therapist. Guys have a pelvic floor too, and you deserve treatment. Thank you for tuning in. I appreciate having you here. Care for yourself like you are the most important person on this planet, and exercise like your life depends on it, because it does. Let's talk again soon.